Now that I think the next the case will be the total pancreatectomy. When, where is this operation feasible and safe in India? Dr. Vivek, please.
Thank you, chairpersons. I bring greetings from Max Hospital, Vaishali and Patpagan, and just like Dr. Puneet Dhar, I also have very honest disclosure. Can I have my slides there? So I have a very honest disclosure, a very, very limited experience, and not a very good one, as I'm going to show in my slides as well. Coming back to the topic, I think I'm going to talk about when and where. The when is very, very clearly described. When not, probably we need to know better. And the next thing I'll probably try to answer, but feasibility and safety, when we talk about feasibility and safety in India, we have to understand that despite an extensive literature search, me as well as my team couldn't find a single publication looking at total pancreatectomy and its short-term or long-term results from our country. And that's something which we need to look at. So broadly, we can divide indications for total pancreatectomy into 4 things. Something like a pre-malignant and malignant conditions. There are severe intractable conditions which are benign but not amenable to medical treatment or lesser resections. Something which is a conversion total pancreatectomy, wherein you see intraoperatively and decide that it's better probably to take out the whole pancreas. And completion rescue pancreatectomy, and wherein you could kind of be in a situation post-Whipple's where you have a leak and multiple complications happening at that time. The first and foremost indication for a total pancreatectomy remains IPMN. We know that there is a high risk of malignancy in main duct IPMN. The risk is much more in main duct IPMN, and sometimes in branch duct IPMN, if it's multifocal, then you would need total pancreatectomy. In main duct IPMN, you may need do it upfront. There is some controversy about this. In some patients, if there is margin positivity, then you would do a partial resection. After a partial resection, you would do a completion pancreatectomy, and then multifocal branch duct IPMN would also probably need a total pancreatectomy. Now, sometimes you will find that there is multifocal pancreatic cancer. We know that this may happen more often in chronic pancreatitis, but you may see it otherwise as well. So there is a head tumor, there is a tail tumor, there is a head tumor and a body tumor, wherein very little pancreas would be either left, or leaving behind the remnant pancreas wouldn't be that advisable. There could be some different concomitant pathologies. For example, you have an IPMN and an IPMN invasive adeno-CA in the same patient, or you have a neuroendocrine tumor in one part of the pancreas and another established pathology in the other part of the pancreas. Nesidioblastosis is a condition which is a hyperinsulinemic syndrome and relatively less well studied, but this is one situation wherein a total pancreatectomy has also been described. As regards metastasis to the pancreas, we know that RCC mets can happen, wherein it can be a situation in a RCC that there are only isolated pancreatic mets. Single, multiple resection seems to be the way to go about it, because these tumors tend to, these patients, even though they recur, they systemically tend to do well and they have good survivals. And then another genetic syndrome, von Hippel-Lindau syndrome, multiple neuroendocrine tumors or cystic lesions may need a total pancreatectomy. Coming to chronic pancreatitis and recurrent acute pancreatitis and total pancreatectomy, the rationale seems like a logical operation in this thing. You have multifocal site of disease, inciting recurrent inflammation, the whole pancreas is diseased, take it out, reduces the pain, yes. Improves quality of life, yes. When there are studies which have looked at total pancreatectomy in patients who have undergone a total pancreatectomy for refractory pain, post-surgical procedures, there has definitely been an improvement in the quality of life. It doesn't reach the normal population, but compared to their painful state, it does help them. It definitely eliminates the risk of pancreatic cancer. Now, it is very important at the same time that we select the patients judiciously. Refractory pain, you have to have a documented chronic pancreatitis, probably a failed previous operation. Diffuse parenchymal small duct disease, we heard Dr. Ramesh the other day talking about beautiful role of non-completion, non-total pancreatectomy surgery, drainage procedures in small duct disease. Probably that's a better way to go about it. Recurrent acute pancreatitis with impaired quality of life, and select group of patients in whom there is hereditary pancreatitis with either documented chronic pancreatitis or patient is having repeated episodes of recurrent acute pancreatitis. Coming to total pancreatectomy for hereditary pancreatitis, we know that hereditary pancreatitis is associated with mutations in PRSS1, SPINK1, CFTR genes. Out of these, PRSS1 seems to be the most studied, wherein the risk of cancer is very well established. When I was preparing for this presentation only, I realized that we see so many children with recurrent acute pancreatitis, wherein I really don't know how many of us are really looking at these genetic mutations, but the literature seems to say that 50 to 70% of pediatric population with recurrent acute pancreatitis will have these genetic mutations, and we should be looking at them. The risk of pancreatic cancer is well studied in PRSS1, and which is nearly says that the risk of pancreatic cancer in these patients goes up to 50%. And this is at 15 to 20 years duration of time from the time of diagnosis, and the risk further goes up in smokers. It improves quality of life in these patients. It eliminates the cancer risk. To know which patient we should actually do is still not known, but what is known is now that delayed surgery in these patients doesn't help them much. So what is being said is, we are still not clear which group of patients we should offer them early, but when you know that this patient needs surgery, it is good to offer them early. Difficult conundrum to answer. When we are talking of total pancreatectomy for hereditary pancreatitis or chronic pancreatitis, important role of islet autotransplantation. I think AIG is doing some work on this, but when I try to figure out other places, there's probably not much work which is happening in our country, unfortunately. This total pancreatectomy part gives good pain relief. There is some morbidity, there is mortality, the long-term sequelae are there. But if you do islet autotransplantation, then in some subset of patients, you'll be able to have them insulin independent. And more importantly, probably when we look at insulin independence, what we realize is that if we keep that goal or bar so high, you will lose out on a lot of patients which will benefit from this procedure in making their diabetes more manageable. And I think that is something which still remains a challenge. There is significant pain relief with this procedure, significant decline in opioid use, and in a significant proportion of patients, you will be at least be able to get their diabetes to be managed better with an islet autotransplantation. Again, we know that when there is a long-standing disease and when the patient already has diabetes, the islet cell yield is not that much, making the results of islet autotransplantation not that great when the patient has had a long duration of illness. Going to the next indication, conversion total pancreatectomy, the first and foremost indication which has been described in the literature, which somehow in whatever I have seen so far or been part of my practice hasn't happened that often, wherein we've gone ahead, found that the pancreas was very soft, the duct was very dilated, there were some pancreatitis changes as well, but then we have stopped short of doing a completion pancreatectomy and probably burnt our fingers as well. But the literature describes a large subgroup of patients wherein probably this would help. A soft pancreas, dilated small pancreatic duct. More importantly, we know that when arterial resections and reconstructions are being considered, there is a significantly increased morbidity and mortality in these patients. So whether this subgroup of patients benefits from a total pancreatectomy, avoiding the morbidity and mortality of a pancreatic leak, or probably somewhere where in the line you would say, yes, this patient has an arterial resection, reconstruction, a small duct, a soft pancreas, putting three together. The answers are not really yet, but these are points to ponder and where we could probably be looking at coming up of total pancreatectomy in a bigger way. If obviously there is a tumen extension to the left side of the pancreas, the margins keep coming positive, then it becomes an option. And sometimes, rarely, when there is massive intraoperative uncontrolled hemorrhage, that is a situation wherein total pancreatectomy has also been described. Coming to the topic of high-risk pancreatic anastomosis, surprised to find a recently published randomized trial on this subject from Italy. They talk about 61 patients wherein they have done pancreaticoduodenectomy in half and a total pancreatectomy with islet autotransplantation. Very difficult to replicate. Most places we don't have islet autotransplantation, but food for thought. Significantly higher morbidity after a pancreaticoduodenectomy. Mortality, though looks different, but not statistically significant. Shorter stay with a total pancreatectomy islet autotransplantation, no differences in DFS, OS, site of recurrence, disease specific survival. When we look at what I was talking about islet autotransplantation, earlier we were talking largely of benign disease, but this is a study which has gone ahead and done it in a patient with proven or largely suspected cancer, and they've got still good outcomes in terms of oncological survivals as well. Similar retrospective study trying to say the same thing, that the morbidity probably may not reach statistical significance, but when you look at those numbers, the stay, the cost of management of these patients, the risk to life, probably all those things probably would do change. And these patients obviously would require more interventions if you've tried a pancreatic anastomosis. Coming to a more dreaded situation of a completion rescue pancreatectomy. Now, this is one situation, we've done a pancreaticoduodenectomy, we've done a PJ, it has leaked. You've been trying PCDs, the patient then suddenly develops a massive hemorrhage, your IRP person has tried something, it has seemingly worked for some time, and then you are facing the worst nightmare, you have a leak, you have a bleed which is not getting controlled with interventional radiological techniques. Infrequently required, and this slide actually shows my initial thought. I actually penned down this slide before I actually read back the literature, and then I tried to find reference for this. My thought was, it is infrequently required. Most complications can largely be managed by IR. We can sometimes manage them conservatively. and it probably shouldn't give any survival advantage over drainage. The only point which I could find was the last statement stood true, but how true, we'll have to look at that. 4 studies published from 1992 to 2022, largely saying the same things. But the important message there is that when there is a large series, you see a 2 to 5 to 6% incidence of a completion pancreatectomy having been done. The latest series I'm going to show is from Dr. Buchler from Heidelberg, and they have also shown out of their 4,000 pancreaticoduodenectomies, I'll just bring on that slide. So around 4,000 PDs, 39 if I'm not wrong, 120 completion pancreatectomies. And I probably feel that when we look at the mortalities, very high mortality, 37%. But I think the important thing to realize for us surgeons is that we are looking at it is like 1/3 empty or 2/3 full. You look at it as like 37% will seem a very, very high mortality. But when you look at this subset of patients, we are faced with a patient who is the worst nightmare for majority of us. Your patient who's leaking, bleeding, and you know that you are going in this patient when you know that this patient is very unlikely to make it. And if you are able to salvage 2/3 of them, or even half of them, or even I would say 25–30% of them, you would have a fair and square discussion with the patient's family, telling them the risk, telling them the high likelihood of still mortality, need for reprocedures, but then probability of salvaging these patients might be there. I'm not batting for this, I'm just honestly showing you the evidence, my bias against it, but then the literature seems to be supporting a big role of completion rescue pancreatectomy. Coming to the procedure per se, the intraoperative considerations, technically, unless there is a very big tumor, you are doing some concomitant vascular resection anastomosis, it's actually a simpler operation to do. In literature says that in 20% of patients, we will be able to salvage the spleen, so we should try and salvage the spleen when possible. So obviously that will depend on the indication. And if splenic preservation is not feasible, now this first line doesn't come across very well in the literature, but this is when the only case I have done, I'm going to show. We actually accidentally ligated the left gastric vein. And after doing the total pancreatectomy, the whole stomach was congested. And when we thought back about the case, we realized that if you are doing a total pancreaticoduodenectomy in a patient, left gastric vein is the only draining vein which is left. Very important in these patients to save the left gastric artery, and somewhere along the line when there was a discussion happening yesterday when it was being discussed about pancreatic body tumors and celiac resections, when you're doing a total pancreatectomy there, important to salvage the left gastric artery. I think it was Dr. Punidhar or somebody talking about it. Or if your stomach becomes necrosed, you will have to add a gastrectomy there to the procedure. When planned, the morbidity and mortality for this procedure seems to be reasonable. The serious morbidity is there, but when it's an unplanned completion pancreatectomy, the mortality and morbidity tends to be high. I'll try to rush through my slides and seeing the time is up. The long-term sequelae important thing is diabetes. The patient needs lifelong insulin. The bigger problem is the hypoglycemia unawareness and the unpredictable response to insulin, which has been described as brittle diabetes. And you talk to a lot of people, they say that diabetes is brittle but not that brittle. I don't know how you define that, but probably endocrinologists who are regularly managing patients with type 1 diabetes dedicatedly would be good people to liaison with when we are talking about this. Malnutrition needs pancreatic enzyme replacement therapy, and there is a significant impact on quality of life. As regards long-term survival, when I started off making this presentation, I was very skeptical about this procedure. I'm much more optimist. There is data which says that people have achieved 71% 5-year survival with a median follow-up of 34 months. No deaths owing to hypoglycemia in one series, reasonable insulin and pancreatic enzyme requirement. Dutch pancreatic cancer group is talking about a moderately reduced quality of life compared to a normal population, not to a diseased population, and just a less than 2% mortality from hypoglycemia or malnutrition related complications. This is just another study talking about quality of life. This issue becomes very important in these patients. So preoperative preparation is largely counseling the patient and ourselves being prepared about the procedure and its long-term sequelae and its management. Post-op management, largely management of the ensuring a glucose homeostasis. Pancreatic enzymes have to be supplemented. The same thing continues post-operatively. You will need to give adequate doses of pancreatic enzymes. Now coming to this slide,
I think I have wind up fast.
Just 2 or 3 time is already up. We'll finish before time. 11 o'clock we have the session and finish before time. So total experience is very, very limited. And this is not just my cases. Very honestly, this is 2007 to 22. Any place that I have worked, I have been part of or followed up any patient with total pancreatectomy. The indications are understood. The important figure which comes across is that I have not seen a 1-year survivor. My experience may be very different from a lot of people sitting in the audience here, but then we have to understand that there are lots of issues which we have to handle. the non-compliance with insulin becomes an issue because the hypoglycemic loss of consciousness leads this patient to having to rush to a hospital, needing an IV access, and non-compliance with pancreatic enzymes because of the cost is an issue. I think the important thing, I'll just quote Atul Gawande here. I think as we look at all this, we look at our data, and probably we should hopefully be looking at some other data coming from our country. We can definitely get better. It will just take diligence from ours, and most importantly, it will take a willingness for all of us to come together and try. There have been a lot of recent advances in terms of 24-hour glucose monitoring, better availability of insulin, probably dedicated care given to these patients, centers of excellence, working as a team, some mechanism of reducing the cost of pancreatic enzyme supplementation, and probably a registry data wherein we could actually be looking at this, and probably registry would just not be looking at the data. It will be important to learn from the centers which are doing well. That will help us get better at this. So to summarize, total pancreatectomy is a feasible and a safe operation to be done judiciously after due diligence. There are significant long-term sequelae, and when we are planning to go ahead with this operation, we have to dedicatedly decide that we are going to support this patient for his life, and it is going to take a lot of dedication, a lot of effort from the entire team to get these patients to do well in the long term. Thank you very much.
Right, thank you for excellent presentation. As we all know, I think this is the procedure, but not many of us have really performed in their entire career. And I suppose most of the time the indication, as you rightly pointed out, is in patients with following Whipple as a rescue the problems. The patients, the bleed, the pancreatic fistula, intra-abdominal abscess, everything, I think. Those patients are really the one which is very difficult to survive. And in majority of the cases, more people will just come out actually, rather than doing even the rescue total pancreatectomy. So technically it is not a problem. It's basically the after surgery, it's basically to supporting the patient, the insulin problem that creates a problem actually.
I think the answer there probably, sir, is like when we look at the Western data, they have been able to get across a lot of people. And I have talked to Dr. Ramesh and others as well. So they say that the diabetes is not that brittle. Probably it is just opening up of our mind to the ideas that we need to manage them better. And people who manage type 1 diabetes, I think there are kids who live their normal lifespans. No reason why with good care, dedicated care, we should not be able to get them across. If the world can do it, I think India is there now where we can try and do it. It's just about coming together of minds and trying to find solutions to these problems.
Right. Any questions from the house?
I mean, I think that diabetes, the risk is overstressed. It's probably many of those are the ones which are bad conversions, so that's why the survival wasn't so high. All the ones I've done for elective ones actually did brilliantly well. You know, I had, just like ampulectomy, I had a mental block in my mind that this is a very, and what I wanted to say was the insulin requirement actually, because there's no glucagon and all that, is a trivial, but it should be done in educated people because they can be hypoglycemia, unawareness and all those kind of things. So it was a trivial 8 or 10 units only they were controlled for the, you know, at least for 2 or 3 years that I followed up. So there is it's not that bad as we make it out to be.
Can we have a show of hands? How many in the audience have done total pancreatectomy? Just a show of hands. Good. Can we learn our mutual experiences? Share.
Yeah. Just one thing that, one thing you missed is a duodenum preserving total pancreatectomy that is specifically defined for nicidoblastosis. We have done it in a child, 2-year-old child, and now he has grown up to more than 8 years now, and he's not having that problems of recurrent hypoglycemia. Second thing, which I think with PD, with bleed, I think what I was learning now, it has been with the complications with the PD that you do a completion. But what we have faced is that a margin repeatedly coming positive. You're resected, you feel that there is margin positive, and then on frozen it is positive, and then you have to resort to a total pancreatectomy. So these are 2 experiences that we had. We have total done 3.
Yes, so I have a comment and, 2 comments actually. One is about the genetic mutations that you mentioned. So the PRSS1, as you correctly mentioned, or the cationic trypsinogen gene mutation, is the one which causes tumors. I've tried to do an extensive literature search, and in India I could find only 1 case in the last 25 years. So I think Dr. Pradeep will have a large experience from AIG where they do a lot of genetic testing. I've sent a lot of my patients for testing, but I don't think that this is a mutation which really exists in India, unlike SPINK1, which is an association, but does not lead to tumor at all. That's the first comment. The second is about the diabetic control. So I've done for pancreaticoblastoma in an 8-year-old boy. I've done it for multiple tumors in the MEN1 syndrome, which have been throughout the whole pancreas. These have been young people. They adapt beautifully. The chap with pancreaticoblastoma is attending college this year in the US. But the elderly, when you do it for the IPMNs, when you do it for multifocal pancreatic tumor, when you find that the 65, 70 years old, at this age they find it very difficult to learn, recognize the signs of hypoglycemia. So I don't know whether there's an age factor in literature, but I think beyond the point, even if they're educated, they find learning how to manage this hypoglycemia or recognizing the symptoms with old age much more difficult than in the teen and the young.
Sudeep has brought up. When we are planning a total pancreatectomy for a patient, the presence of a social support, educational status, and the ability of the patient to understand the ability of a patient to adapt to that lifestyle and the consequences is very, very important. So the counseling of the patient and our assessment whether this patient is subsequently going to take it. Dr. Pradeep, you wanted to add something there, sir?
Yeah,
please.
actually, Pradeep,
It would be nice for us to learn from each other's experience.
Yeah, I just want to ask Pradeep also just to add one question. Your center was just actually probably involved in the islet cell the Aura transplantation. What is your experience actually?
So we have done this transplant only for chronic pancreatitis where a limited resection is there for feasibility study. But not in total pancreatectomy in chronic pancreatitis. We are not yet started because we have to get a clearance. It's only auto transplantation only where limited pancreatic resection was done. So for benign condition, so we extracted the islet cells of the patient and then injected back into the portal vein into the liver. So this is a preliminary study. The second thing, I have 4 patients where I had to do a total pancreatectomy. As everyone has highlighted, doing surgery technically is not a major procedure. Technically it's very simple. The biggest challenge I found was one patient died. She is from Malayali from a village. So she was okay for 1 year, but she was found dead at the house when they went in. She is hypoglycemic. So the biggest challenge is not the high sugars. The biggest challenge is the hypoglycemia. Unawareness is a big problem. So unless, as you highlighted, I think educating the patient is more important.
I think
and whether the patient can manage, whether support system is there, I think we should be very selective in those patients rather than.
That is what we faced in one of our patients also. The patient used to come like every second day to the emergency. So one day she decided to stop taking the insulin because when these patients experiment, they realize that they don't have to rush to the hospital immediately every alternate day if they stop their insulin. And then they come with hyperglycemias and opportunistic infections and they are losing their weights. They're just becoming malnourished, and that's probably education is the way to go about there.
And for post-Whipple's, this thing we have not done, though it is literature. So 3 or 4 cases we had to go in because of the complications, but we somehow managed with pancreatostomy and we were able to save all these 3 patients, of 3 or 4 patients. Just create a pancreatostomy, don't do anything, just drain the collections, and I think initial that point of time we felt that pancreatectomy might be unnecessary.
Yeah, that is what I think most of the people will do it actually. Just put multiple drains in that the devastating situation. So is there any last minute question? Yeah.
We have short experience with tropical virus multifocal tumors and main duct IPMN. Our experience has been like what others have echoed. In those who are educated patients, the diabetes control is not difficult. It's important to communicate these patients, ask them to communicate with previous patients who had undergone so that they can understand the philosophy and communicate with the endocrinologist very frequently. Another important aspect is the exocrine supplement and the cost involved with that. We need to upfront discuss with this patient because around probably 60,000-70,000 units per day is the requirement which we need to upfront discuss, and some patients who are not affording may slip out of this regime and they will end up with major nutritional consequences.
I think for this rare surgical procedure we could have something like the multicentric study which was published on cystic neoplasms of pancreas, and probably the IASG would be the best platform for people to share their data. Somebody could make an Excel sheet, give the points. We could have some very, very basic information there, and probably we could figure out which center was doing better and probably learn from them as well.
Right. Thank you very much for
Thank you very much.
excellent presentation and the good interactive discussion. Thank you, Vaishnav.